Good morning. Hello, everyone. My name is Dr. Misbah from Professor Wu's team. So thank you for inviting us. So actually, Professor Wu have some important issue is in the flight. So flight is delayed. So I take in charge. So first of all, I want to introduce our CTO week from China. Like today, the CTO week chairman, Professor Liu, Dr. Zhao Jia, and Dr. Wu Jiang. So they will deal the CTO PCI live case from here. So I would like to request Professor Liu, chairman of the CTO week. Actually, the CTO week, more than 50 to 60 cases, we joined together 16 hospitals from China, and 1 week we finish at least 60 cases CTO case.
Sure.
That'll be really great. We'd
Well,
love to be part of it.
So now I request to talk about the CTO week. Thank you.
Sure.
Dr.
Hello,
Jiang,
Dr.
Wu Jiang. Yes. Yes, sir.
Yeah, I'm here. I can hear very clearly. Hello, everyone.
Very good.
Hello, Dr. Zhang. It's great to have you.
Yeah.
We can see some good
I'm
pictures.
Dr. Zheng Wu from Beijing Anzhen Hospital. From the, Professor Liu Jinghua is my boss, and Professor Wu Yongjian, as you know that, is my teacher, and in my team is Dr. Li Yingkai. I'm Dr. Wu. I find a really, really interesting case and want to share you with my live case. 麻烦把那个术前的那个 PPT. Yeah. Could you show you? Can you see the PPT show on the screen? Yeah, it's a baseline. It's a baseline of the patient. Could you see my slide?
Yes, we can see very clearly
Everyone?
your slides. We can make out.
Okay. I will introduce by myself. It's a 61-year-old male and with typical angina over 5 months and almost 4 months ago in local hospital. The angiograph show there is a 3-vessel disease in the patient, very severe, and the left descending artery is totally occluded, but cannot find exactly the entry point. And after that, the patient in the local hospital implant the stent in the right coronary artery and in the circ. And after that, the patient also felt some discomfort, maybe related to the effort. So I think the LAD CTO lesion is so important to this patient. The patient has normal cardiac function and normal renal function, but the patient combined with hypertension, hyperlipidemia, and diabetes, and the index controlled not very well. And after that, we plan to open the LAD CTO another time. And before the procedure, next slide, please. And before the procedure, I can show you the baseline angiograph in the local hospital after the stent in the circ and after stent in the right coronary artery. And you can see there is so clearly connection from the right side to the left side. But I think it's a quite important thing to this patient is we cannot find the proximal cap, and there is so many side branch just beyond the proximal cap. And also we can see that the distal cap of the lesion is not very clearly. And also there is several branch around the distal cap. And you can see that the distal landing zone is not very good for this patient. Even if the patient have a good collateral from the right side to the left side, I don't think the patient can deal with the PCI intervention from the antegrade approach. I don't think it's easy to done it. So it's a baseline angiograph before the procedure. And after that, we perform a coronary CTA scanning before the procedure, and we can find it's a so long CTO length, about 40 to 30 millimeters of the LAD CTO lesion, and in the CTO segment, we can find the spot calcification, very severe calcification in the proximal cap, in the distal cap, and in the segment of the CTO lesion. So I think it's not a very easy case for me because the ambiguous proximal cap, because the distal bifurcation with the distal cap and the so long lesion with combined with calcification, and you know that during the proximal to the distal of the LAD, maybe there is some bending. Of course, there will be some bending in this segment. So I think it at least three score, JCTO score for this patient. And I can show you the angiograph today. So
Great. We'd love to see that.
Can you see the
Yes,
angiograph?
we can
in
see
the
very
screen?
clearly. Very nice images.
It's a first angiogram today. You can see the stand in the right coronary artery and the stand in the circ is all the pattern. It's very good. And the only problem is the LAD CTO lesion. And from this view, we cannot find very clearly the proximal cap of the LAD lesion. And we can only find there is a calcification just beyond the LAD CTO lesion. And from this view, we can also find that there is a severe lesion in the PD artery. You know that? You can see that? So even if there is a good collaterals from the septal, from the right side to the left side, but there is a some lesion in the PD artery, it's a first view. So yeah, it's a next view, it's spider view.
It feels very more important.
Yeah, from this view, we can see more clearly about the proximal cap. Just there is a remus and a big circ, and just beyond the remus is seen the proximal cap. But I think it's not very clearly because there is so many side branch just beyond the proximal cap. So next view, yeah, it's a right side cranial view. So from this view, we can see so poor landing zone. Is that right? So poor landing zone. So I think if the wire falls into the subintimal lumen, it's quite difficult to re-enter to the distal because the distal landing zone is so poor. But the patient has a good collaterals from the right side to the left side. So if the antegrade wire falls into the subintimal lumen, maybe I can switch to the retrograde approach. And you can see there is so many diagonal during the segment of the LAD situation, but not a diagonal is so big. All the diagonal is middle size, or the small size, not the bigger size diagonal. So next view. Yeah, it's a left side cranial. Yeah. From this view, we cannot see very clearly the CTO routine. And the next view, yeah, is a right side caudal view. Also in this view, we cannot see very clearly the remus and the relationship of the remus and the proximal cap. So after that, I only give the patient caudal view. So next view. Yeah, it's a big caudal angle. Big caudal angle and a small angle of the left side. So from this view, we can see exactly clearly of the proximal cap. and it seemed some contrast can go through the CTO segment, but I'm not sure whether or not it's bridging collaterals or other cell branch or it's loosened tissue. I'm not sure. So it's the baseline angiogram today. So I want to give my some good comment or recommendation or suggestion about this case because I think it's really not an easy case. Thank you, everyone.
Thanks for your introduction for this case, and thanks, Dr. Ovik. Great work. We have a good opportunity to communicate with each other, with Pakistan and colleagues. So we have several minutes to discuss this
sure.
case.
So please.
Can we have some suggestion from the Pakistan colleagues, please?
Yeah. Any comments? What wire are you? I mean, getting from the right coronary to the left system is always a challenge. The collaterals are not well visible. There's certainly no antegrade flow, and you cannot. It's very ambiguous antegrade origin. So retrograde is a very good choice. Any thoughts on by the panelists? We'd love to see how you proceeded because it's a real challenge. It's it's a good case for retrograde, but having said that, it's always a challenge to get from the right coronary artery into the left system. And to be honest, from where I see, it's been pretty tricky working out where the collaterals are entering from. There are 3-4 branches in the right side, and your wire was in the smallest of them. So I wonder how you proceeded. Any comments from the panelists?
Yeah. Thank you, sir. I totally agree with you.
Wire
Because from the right
is
side,
our primary strategy.
from the
Like
right side to the left side, we
or
can.
Bongo. Yeah, then Guy second.
No,
Guy
please,
third.
please.
If the integrate wire escalation fails, the bailout retrograde wire escalation.
Yeah, but you know, I mean, having said
It's
that,
not a case for dissection re-entry because it's a long segment. So antegrade and retrograde wire escalation will work here.
Okay, that's a good thought. So can we proceed with the case?
Well, unfortunately, there's a problem here in the monitors. It is switching off and on frequently, and we are trying to reorient it. What is happening?
It's a pretty good image over there, actually. Yeah.
Yeah, right.
Can somebody fix the piece
So we have two choices of retrograde approach, retrograde channel. The first one, you can see very clearly the apical cathode channel from the acute marginal, from the acute marginal to the distal landing zone. I think it's a good choice because we can find a good attacking angle, and we can have long attacking zone. But I think the epicardial channel have some risk when we cross it because it's so tortuous. And another choice for the retrograde channel is septal. You can see that, of course, there are so many choices from the right side to the left side from the septal channel. But all the septal channel can get relatively high level of the LAD situation, maybe get in the segment of the LAD CTO segment. So I think even if I can cross it from the septal channel, maybe it cannot be used just because the channel can connect it so high level, not to the distal cap of the CTO lesion. So I'm so confused how to choose which channel could be the first choice for this patient?
So Dr. Wu Zhen, can you hear me?
If you want to perform the therapy by a risk-grade approach, you can choose the RAO caudal veil to veil the entrance of arteries. So if you want to perform PCI by a risk-grade approach. But for this patient, we can see very clear from the spider web we can say is the tape stamp. So at any time we can perform the PSI by integrated approach.
Yeah. So what do you think about some vessel in the CTO segment? Is a breeding collaterals or side branch or is losing tissue in the CTO segment, Professor Liu?
Yes.
So what do you think about it? I don't know whether or not my wire can go in through the CTO segment very smoothly. I'm not sure because I'm confused the anatomy of the situation.
Yes.
Anyway, Dr. Wu, Dr.
Yeah,
Anyway,
Professor Wang.
My opinion, you should try integrated approach first. And we believe that your feeling will tell you which route is correct.
Sure, of course.
There was a
So
suggestion
what do you
here
think
to try and
the
integrate
first
again.
wire, which wire is appropriate for my first attempt?
You can use the polymer jacket wire XTA or XTR to try it.
Yeah. So I can make the integrated preparation and make the wire as far as possible. And even if it falls into the subintimal room, I can switch to the retrograde approach. But if I cannot find the proximal cap, you know that maybe the wire can go out of the vessel structure. I think it's quite dangerous. So the first wire is important.
If I may make a comment. So I agree entirely. I think that the course of the LED
Recording in progress.
The course of the LED is not known. There's some calcification. What about taking just a soft field or XT, knuckling it, and then dissecting it proximally? That'll give you an idea about the course of the vessel better. If it goes nice and smooth, you may be able to come closer to the distal cap and have a better idea which septal collateral may actually connect. And as it is, I think you'll need that integrated wire dissection anyway. I personally wouldn't go with an aggressive wire to try and cross it with a wire, but I think a knuckling technique would be a reasonable approach.
Hello, I'm Dr. Ra from Korea. Can you hear me?
Yeah, very clearly, please.
Okay. If I do the case, if you look at this spider or epicaudal view, you can just when we depend on this fluoroscopy image only, you can see the fluoroscopy classification from the leptomean RTL area to the proximal LAD. It means that the continuity of this fluoroscopic classification, you can assume that the stump must be definite LAD RTL area. So by depending on the fluoroscopy, we can start the LED must be the visible LED also secure stump. So we can just simply start an integrated approach by the starting with the CTO integrated approach. But if you are not 100% confident, then maybe you can do sequentially IBUS assessed by the inserting IBUS catheter into the ramus and then confirm the RTL area of the LED, then definitely you can start or the real-time IBUS guided CT wiring from the LED. But I think this case is nearly not so difficult to confirm in the LED RTL stump by the fluoroscopy. So just to simply start. But I want to comment on this because you have done multiple injection by bilateral image by the guiding catheter. It consumes a lot of contrast amount. So we are not stopping procedure by the radiation dose on the index procedure. So we have to minimize the contrast. So in my case, I'm doing only the one bilateral image, the most required image. The other image is just a simple retroid image, the required image for the just to see the interventional collateral, what channel we have to use, something like that. So too much contrast consumption should be avoided for this particular case. So I would like to strongly recommend integrated approach first with like XTA for the total. Yes. And then If things are not going easily, then you can quickly switch to the bidirectional approach with retroid in the septa or the any feasible channel in the middle portion of the LED. There's a good feeding collateral from the RCA. You can use that. And that is my comment.
Yeah, thank you. Thank you for your suggestion. And do you think the sliding wire and the soft sliding wire is your first choice for the,
yes,
you can touch
I feel,
the proximal cap? Yeah.
Yes.
Thank you.
Because
Thank
you can see some multiple staining, focal visible. So it means the sliding technique is the first option to start with. So XTA 1.0 gram is the first choice in my opinion. And then if things are not easily going, then you can switch to the Gaia 1. Gaia first, or the step up to Gaia second, something like that.
Yes.
Yeah. Thank you.
You can go ahead.
Contrast,
So what is the final plan, Dr. Wu? What is the final plan?
I can hear.
contrast modulation in proximal LED, like a Carlino, can also help in the wire manipulation. Contrast modulation.
Actually, the diagnostic image showed LED going into a diagonal almost in mid-vessel. So this has progressed since that angiogram. So maybe if you can get the antigrade wire going antigradely and then seeing how far it goes. And sometime just channel surfing can help us get into the LED. There are so many collaterals from the sepals going from the right side. We can surf different channels, and if we can get into the distal LED by surfing, then maybe we can connect with the proximal wire coming down antigradely in the LED. So let's see how far the LED wire goes antigradely, and then we can try and channel surf from the right side. And there are multiple collaterals. Some of them are very good. Sometimes you don't see the connection, but you can go across very well. So maybe just surfing and seeing how far you go, that would probably be a good way of proceeding. Sometime what we do is we take a micro into the different branches of RCA and give injection through the micro and seeing if that connects. And if that happens, then you can use the same micro to take your wires antigradely and try and surf there. That's another way of doing, at least, that might help.
Yeah, thank you. So I will try my best to send my antigraded wire to the distal. So as you suggestion, most of you suggestion, my first wire is a soft polymer. Jacket wire is filter XTR is a Corsair Pro microcapacitor, single lumen microcapacitor. And I think it's quite easy to find some resistance point of the proximal cap. It's quite important because there is several set branch and maybe raging collateral. So the resistance point, I can find it using the filter XTA wire. And after that, I manipulate the filter XT wire very carefully and push and a little bit rotation and push forward. And I can feel some resistance, but the resistance is not so high. And I can send the filter XT wire to this level. I think it's quite good feeling, quite good feedback of my hand. So I stop the wire here. You can see that. I think I can go into the C2 segment. It's quite important. Whether or not it's in the true lumen or in the sub-infrared lumen, I'm not care because we have good collateral. So the first important thing, we can find the vessel structure. So after that, I can confirm it.
Do you think a retrograde injection will help?
Yeah. From this wheel, from IO cranial, we find something make me discomfort. You know that in the C2 segment just in the middle segment of the CTO segment. From the right side, from the distal channel, we can say it seemed some gap between the retrograde and the antigrade wire. You know that? You can see that it's a small gap. So I'm not sure at that time whether or not my wire in the fourth lumen or just I think the plug tracking. So in this point, I'm confused. Or only I can confirm is my good hand feeling, because in this wheel, I can send the wire to the distal, to the diagonal. You can see that to the diagonal very easily. So, so I'm not confirmed whether or not the wire in the fourth lumen or just in the plug, not in the fourth lumen.
I think you
it
can
looks very good,
change a little bit the
Dr.
view
Hu.
to
Maybe
show us.
if you have a problem crossing with this XT, you can escalate, advance the Corsair and exchange for a stiffer wire and try and puncture through the proximal cap and get into the LED. You're so close to the LED here.
Yeah. At that time, I can perform the parallel wire technique because I think the true lumen just enter the wire. But the hand feeling told me the wire not in the fourth lumen, it's in the true lumen because there's no resistant feedback from my hand. So you can see that I can send the wire easily to the side branch, to the diagonal.
Yes, that
So I
suggests
don't
that we are
think
the
the
true
wire
lumen.
in the subinterlumen. Maybe in the plug, in the true lumen, not in the subinterlumen. But the next problem after that is it quite difficult to send the wire continue to the downside of the LED artery, because you can see that just after the small diagonal, there is a severe calcification. So after that, when I withdraw the wire back and to the distal, I felt much resistance because I use a filter XC wire. And after that, I escalated the wire from filter XTA to the pellet 200. You can see there is a calcification. Just beside the calcification is resistance point. And when I escalated the wire to the, yeah.
You should have asked us the next where you should choose.
Okay.
Yes, maybe you can change another way, not polymetric. Maybe Gaia, maybe.
But interestingly,
yeah.
Your answer is exactly the wire you chose.
Yeah, I didn't use Gaia series wire just because there is a calcification. The main reason is calcification. I don't think the Gaia series wire in the severe calcification will be a good choice because can stuck by the lesion. And I can see there is maybe there is some channel, and just because of the severe calcification, so I escalated the wire. Also, I choose polymer jacket wire from the filter XTA to the pellet 200 because pellet 200 has more powerful penetration compared with filter XTA. And after that, you can see that the pellet 200 can go through to the the other diagonal. I think this diagonal is more bigger size, more big size than the previous one. And after that, yeah, you can see that I can go smoothly use the wire to the distal diagonal. So this is a second problem. I think the third problem is you can see the classification, because I want to push forward the integrated microcapacitor and exchange a workhorse wire to the diagonal, and maybe I can use a dual lumen microcapacitor, use another wire to the distal landing zone. But you can see I made much resistance because of the Corsair Pro cannot cross this segment of the situation. It's a Corsair Pro microcapacitor.
So Dr. Wu Zhen, can you hear me? Dr. Shaoliang
Yeah,
Chen.
very clearly.
Yeah, Dr. Chen Shaoliang is speaking. I'm in Pakistan to watch your live cast. Very congratulations to your excellent cast. So angiographically, I feel the wire in the true lumen. So, but I think I need to do bilateral angiography to confirm the exact position of wire in LED.
Yeah. So we can reshape the wire and use another direction to direct it to the distal landing zone.
How about another contralateral injection? I think it's in the LED now. The wire is quite advanced.
You mean we can confirm the wire location?
Yes, with the right injection, and
Yeah.
it looks in the LED.
So I think you can easily take angiography from right corner artery to confirm the CTO wire position.
Yeah. I have confirmed the wire location of the diagonal. I think it definitely in the side branch,
Yes,
but
in the side branch.
not record the image. And I can go very smoothly about in the big diagonal. I think it's definitely in the diagonal. But you can see that in the distal cap is unfriendly angle from the diagonal to the distal LAD. So unfriendly angle, you can see that.
So now
So
You
it's
think
quite
a buddy wire here would be with another micro, a buddy wire this wire can stay there, and you can try and get a buddy wire into the LED with a second micro?
yeah.
Or you can take this micro out and use the same micro to use the buddy wire down into the LED, make an angle.
Yeah, you may use.
Right.
I can reshape the wire, withdraw the wire here, and reshape, make the bigger angle, and
Yeah.
sending the wire to the distal.
Yeah. Or if
The
the
other
micro
option
is not advancing, we can dilate this with the wire down the diagonal. We can dilate the LED so that the micro can go down. And then with that help, we can have another wire or twin pass to get into the LED.
Yeah, I think you told me a good suggestion, but you know that I meet resistance because of the classification just here. And even if I use a small balloon predilate and use a small profile microcapacitor, it all cannot cross the lesion here. All the device cannot reach the level of the bifurcation, distal bifurcation. You can see it's a much resist here. And I use a low profile microcapacitor.
I think the other option and simpler approach is to switch to Gaia third or Gaia second to easily break through the very short occlusion lesion, and just after the diagonal.
We have Dr. Egrid Mohammed and Bilal Murad. They're very good at this. Any suggestions, Dr. Bilal, Dr. Mohammed?
Yes, I mean, I joined a little bit late. I had to step out of I didn't see the case from the beginning, but I'm looking at what I see in here. And you suggested a couple options, I think to me probably the best thing to do. Push this wire all the way down to the diagonal. Try to dilate, take a small balloon. You might have to do a granuloplasty to break that, because you need to change that resistant lesion. If you had laser, this would be a perfect time to use laser in here. And I think I look at the angulation of the LED. There is disease there, but it's open. So dilating into the diagonal, I don't think will compromise it. I don't think a Gaia second or third now will make any difference because you are in the true lumen in the diagonal, and that Gaia second will not make that turn into the LED because it's a sharp turn. So focus on working into the diagonal, opening that proximal part of the LED. If this is unsuccessful with the granuloplasty, there is the case of trying to deliver the rota wire through this microcatheter which take it to the diagonal, rotablade that area, then you work on the distal LED after that. The other option, if that doesn't work, you leave this wire where it is and you dissect around that lesion and kind of crush it from the outside in subintimal space. You have a wire in the true lumen, you could always regain, or you have the access to the true lumen. You crush it from the outside and you work on the wire in the true lumen. So there are a few options that could still be, can be done.
I think it has some method to deal with the problem of the much resistance because of the calcification.
We have 5 more minutes of satellite and then we have to go off. So I wonder how much progress we'll make.
Can I give one more comment?
Yeah, please.
Dr. Salman,
Dr. Salman, have you got any comments for the...
If you carefully observe the baseline image, there must be channel. When you see the retrograde angiography, between D1 and D2, there must be a channel. So it's worth it to try the wire down escalation with the soft one. So hydrophilic, like XTR or the more like a Sion black or something hydrophilic wire with a more acute angle, you can try to redirect into the between the acute angle area under the support of microcatheter. Sometimes this down escalation can easily go down to the LED streaming. Once you fail, then just a short segment redirection with the Gaia second or third penetration strategy that can usually easily make good redirection to the true lumen.
Dr. Ra, you need a very...
to this case, I will simply do the, instead of the complex procedure, simple wire down escalation. If fail, then I will do just a simple redirection by penetration strategy in the short segment.
Yeah, I think my next step for the procedure, I want to reshape a big angle because I think the poor landing zone and the calcification, I don't want to use more stiffer wire. I still try to use the polymer jacket wire, but I will make a bigger band, and I will try a little bit for sending my wire to the distal. But if failed, I will send the wire to the diagonal. Maybe I can use a laser, or I can use a rod ablation, or other method. I can conquer the calcification here. So I will.
Sorry, do you have access to?
If you fail, you wouldn't switch to Gaia second or third.
You without the first
wire is this, Dr. Wu?
Also, we can perform the parallel wire.
Dr. Salman, any comments?
To find the right way.
So I think the catheter seems to be going in and out of plaque. So I think you are probably intra-plaque, then you become extra-plaque. And I saw maybe in some views that perhaps you had a tight angulation, but that diagonal connects to the main branch. So you could basically daughter all the way into that diagonal branch, leave a wire there, then get a dual lumen and see if you can do a hairpin wire and get back into the LED that way.
Yes.
So that's one option.
Well, that's sometimes, I mean, you gain a very good progress at the beginning and you are in the true lumen, the diagonal. Sometimes this is what happens when you take it out and try to reintroduce it. It can become very difficult to get access to the same place, and you become subintimal or really difficult to gain access. But there we go.
No, I agree with that. So I probably wouldn't pull the wire back, because once you have that channel, there's no guarantee you'll get that again. So if you're lucky enough to get into the true lumen, leave it there and then go around it or go close to it. You're right, because sometimes you just can't get back in.
Yeah, Dr. Wu, I asked, do you have access to the turnpike gold?
That doesn't work. Sorry. So as someone who uses a lot of turnpike, it does not work. So
no, that's not true. We publish our series. It is not 100%, but up to 78% of cases it was successful, particularly in cases like this. So you could already, because it's tapered kind of cap, so you could screw it in, and once it hangs in, it does make a change to the complexion of the lesion, and you could easily, after that, even if it doesn't pass, it kind of changes the lesion. You could use a small balloon or even the microcatheter after the normal one, and it will pass. We had a very good success with it. Yeah, not all cases. I said 78%, and we
I think in interest of time, we are out of
cases.
satellite time. So we have to thank Dr. Wu for a wonderfully challenging case. And despite the fact that we are still in the progress, but we've learned a lot from that. We have some more lectures before we break. So Dr. Wu, thank you very much for a very educative case.
Thank
it's
you,
really
everyone.
Challenging. And it was great to have you. Thank you very much from all of us. And a big hand to Dr. Wu and his team. And we love the enthusiasm and the ease with which you reach the stage, but there's still some way to go. So thank you very much, because satellite time is running short and we have some cases to lectures
Thank
to go
you.
through.
Thank you, everyone.
Very much. Great to have you. Thank you.
Thank you.
Before we go with
So
the
I will
lectures,
tell the results of this case to Ovik.
there'll be Juma at 1:30, 5 minutes walk from here. You have to step out of the hotel, turn left, and there's a cargo terminal where there's a mosque, and there's Juma at 1:30. So let's get on with the lecture.